Good luck, Nisha.
Thanks, Isaac. I'll need it. Maybe I'll just be presenting to you.
It would be easier that way.
Hello.
Hi, how are
Hi.
you?
Good. How are you?
I'm good, thank you.
Yeah. Hey, Nisha.
Hello, how are you guys?
Hi, Nisha.
Hello.
So I think I'm gonna start and try to finish in 25 minutes, and then you'll have hopefully more time.
That sounds good.
Great.
Maybe we'll just give it another minute and then delete whenever you want to get started. Are you screen sharing something?
I will try to screen share soon. Yes,
Yeah, it just make
for sure.
you should be able to have you should be able to do that without difficulty, but let me know.
Okay. So maybe I can start now?
Yeah, go for it.
Okay, I will have to the Zoom sharing. Okay, I'm sharing the screen here, and then I'm gonna have to do presenter mode. Yes. Can you see it now?
Yes, we can.
Great, excellent. So welcome everyone to Grand Rounds. Today I will be talking about directed acyclic graphs or causal diagrams, and this is the last session of the year. I don't know if you've encountered DAGs or causal diagrams, but these are very useful contemporary epidemiologic tools that is actually helping with graphic representation of causal effects and non-causal relationships. So, okay. As an epidemiologist, we are very concerned about statistical significance in the lack of causal relationship. So what does it mean? It means that when you're studying a relationship between two variables, exposure and an outcome, you can fit many, many variables into a statistical model or a regression model as long as you have enough power. But the fact that you see statistical significance of a variable in a model doesn't mean that it represents actually causal relationship. So before you enter any variable into a regression model, they should be considered carefully in relation to the exposure and outcome. What is their causal role in the relationship that we're trying to study? It's very easy to just throw covariates in the model and look for statistical significance by p-values, but it is discouraged because it can negatively affect the validity of the inference that you're trying to make. So here's like a general representation of what a DAG is, and in general, we're interested in relationship between exposure and disease or exposure and outcome, but there are other variables that play a role in those associations, and these are called the third variables. And today we're going to focus on 3 of them. We're going to talk about confounders, mediators, and colliders. So before we start, I want to explain why DAGs are important, or maybe sell to you why you need to use DAGs. So first of all, it's very useful to decide which variables we're going to be including in a statistical model. The second thing is that it's very informative when you want to select how to adjust for confounding. So which variables you're going to adjust for. And also, when you plan your own study, whether it's a pilot study or longitudinal study, DAGs can help you plan the data collection. Before you conduct any analysis of the data, you need to make sure that you're collecting sufficient variables so you can adjust for them later or include them in your statistical models. When you analyze secondary data, DAGs are also important because they will guide the analysis strategy. And a third reason, is when you read the literature, you can think about a potential DAG of the association of interest and try to evaluate whether the study has high validity or maybe it's not valid. So let's look at the components of a DAG. So when we see a DAG, we have variables or nodes, and then we have arrows that link 2 nodes or 2 variables. When there's no arrow in a DAG, that means between 2 variables, when there's no arrow, that means that there's no causal effect between the 2 variables. So arrows represent potential causal effect, and no arrows means that there's no causal effect. We usually use A as an exposure and Y as an outcome, although sometimes you will see E and D, exposure and disease. And so U is a common cause of A and Y. It's a variable or a factor that impacts the exposure, but also impacts the outcome, sorry. Okay, so DAG is a directed acyclic graph, and D stands for directed. What does it mean? It means that each arrow has only one arrowhead. And it means that it goes in one direction. It goes from potential cause to potential effect, and it goes directly. So it also represents time, because when you say that A causes B or U causes Y, it means that U came before Y in order to cause it. A, the exposure, is also called parent or ancestor, and Y is called a child or a descendant. And so in this DAG, which one is the parent, which one is the child or the descendant, and what do you think A is or C? And you can put your responses in the chat if you want. So a lot of questions. So what do you think is A? Is it a parent or is it a child?
Is it a child?
So I hate to use that term, but it depends on the context, right? So A can be the descendant of B, but it can also be, so it can be the child of B, but also the parent of Y. So when we look at variables, we need to look at the context, whether they are caused by a certain variable or they cause another variable. So it's always dependent on what we're seeing here. Interestingly, G and B are only ancestors, right? And Y is only a descendant. But C can be either, and A can be either. So these are the components of a DAG. And now let's look at an example. So we look at ghrelin and weight gain. So when you look at these 2 variables, what do you think about their relationship? Is it causal? Is it non-causal? What is causing what?
Is it
Go
direct?
ahead.
Oh, I was gonna say it seems like direct cause, like ghrelin cause you to get hungry, so you gain weight.
Yes. So this is a causal relationship. It's a direct relationship. And we know from this DAG that ghrelin is the ancestor and weight gain is the descendant. But the question is, can weight gain impact ghrelin? Can we reverse the arrow here?
I think you
Is it
can.
possible?
Like,
Mhm.
there's a potential to do that. Why not?
There's a potential to do that, and it depends with the research questions that you
Yeah.
have here. The DAG is representing a research question that is examining the causal associations or causal effect of ghrelin and weight gain. Great. Okay, so what happens when we have a feedback loop? Causal diagrams do not allow us to look at circulary relationships. So the A in a DAG is acyclic, which means that a variable cannot cause itself. We cannot go from A to Y and then go back to A. But what happens when we do have a feedback loop, which happens? So here's a concrete example. Maybe that would be easier to respond to. So weight gain and sleep apnea. So we know that weight gain leads to sleep apnea, but we also know that sleep apnea can in turn increase weight gain. So how do we study that? Using DAGs. Anyone?
Well, maybe it's like that. You kind of drew it already. Like it's a circle, right?
Yeah, but there's
So-
no statistical model that can account for that, right?
Yeah, it's true. Yeah. I don't know.
So one DAG, one statistical model, or one research question. So two ways. The first way to do it is to break it down. Break it down. Let's look at the second model. Look at weight gain and how it impacts OSA, or look at OSA and how it impacts weight gain. Of course, we need to, in causal diagrams, we need to account for temporality, right? So if we look at weight gain, we have to start with a group of people that don't have OSA and then follow them along the time and see who develops OSA and who didn't. The other way around is to look at OSA, people with OSA and people without OSA, and follow their weight gain trajectories. So these are two ways of doing that. So breaking it down into two models. The other way to do it is to take measurements of weight gain before OSA started, and then to continue taking weight gains. And so fit all the variables together, weight gain at time 1, and then OSA at time 2, and weight gain at time 3. So all those variables are going to be included in one model, but they will have different timing. So these are the two ways to break it down. So let's start looking at confounder, maybe the most important variable that we consider. So confounder is also called a common cause, and it's usually it's a variable that is associated with the outcome, but also associated with the exposure. Here in this example, we're looking at eating ice cream and drowning. So there's a famous example of that shows that there's a twofold risk of drowning when people eat ice cream compared to people who don't eat ice cream. So the question is, in this relationship, is it causal or not? Is there any other variable that confounds it? And interestingly, when you look at the summer, that is a common cause of ice cream and drowning, because in the summer you eat ice cream and you go to the beach or to the pool. So it's a common cause. And when you adjust for summer, then the relationship, the so-called causal relationship, disappears. So if you look at the risk ratios, when you fit a model with eating ice cream as the independent variable and drowning as the outcome, the risk ratio is 2. When you include summer as a confounder or as a second independent variable, the risk ratio becomes 1 and the relationship completely disappears. So it's important to account for confounding because without it, you will report biased results. So let's look at mediators and feel free to ask questions if you have, by the way. So a mediator is a variable that lies in the causal pathway between exposure and outcome. If we look at the ghrelin and weight gain example again, you see that appetite may be the intermediate variable between ghrelin and weight gain, which means that ghrelin will impact appetite, which in turn will impact weight gain. So here we see two different pathways going from ghrelin to weight gain. The first pathway is a direct pathway. The second one is an indirect through a mediator, which is appetite. So when you look at the direct effect and the indirect effect together, when we sum them, they are considered as the total effect between ghrelin and weight gain. So direct plus indirect equal total. So this is a DAG that represents appetite as a mediator, and you see that there's a direct arrow goes from ghrelin to weight gain, and there's also an indirect path from ghrelin to weight gain through appetite. So here's another DAG. How many pathways do you see here? This is between smoking and COPD. It's an easy question.
Is it 3 pathways?
3 pathways. Yes. So which one is the direct pathway?
Smoking going straight to COPD.
And what are the other 2?
The indirects are smoking inflammation to COPD or smoking causing tissue damage, and that's causing COPD.
Yes. And so what it means here is that we have 2 indirect pathways between smoking and COPD or 2 mediators. And there is a way to model a direct pathway with 2 mediators in one regression model. It's not done routinely, but there's a way to do that. So yeah, these are the answers that we just said. And when we want to estimate the total effect between smoking and COPD, we're not adjusting for any variables in the causal chain, which means when we fit a regression model and COPD is the outcome and smoking is the predictor or the exposure, we do not include inflammation and tissue damage because that would bias the results. There's an excellent paper that was published in 2009 by Enrique Schisterman, and I recommend reading that. And it talks about over-adjustment bias. So yes, there is a risk of over-adjusting for variables in a model. So we need to be very cognizant of what we're including in a model. So now we can talk about collider. So the collider can be easily explained with the obesity paradox. So what is the obesity paradox? There are many, many publications in different disease populations that show that people with obesity, they live longer. And so those papers looked at patients with heart disease, with heart failure, with type 2 diabetes, with kidney disease. You can see it all over the literature. So what does it mean? Does it mean that really people with obesity and chronic disease, they live longer? How can we even explain that? Is obesity protective of mortality in the presence of disease, another disease? Maybe some of the explanations said that when there is a chronic disease, there's protective effect of obesity. Maybe people lose weight and therefore they live longer. But maybe there's another explanation. So those results were obtained from regression model that looked at mortality as an outcome, obesity and heart failure as predictors. But the question is heart failure really a confounder? Is heart failure causing obesity? Does it cause mortality? So epidemiologists sat down and created a DAG or causal diagram, comprehensive with all the different pathways and variables that may play a role in this relationship. And what they found is that there's a very important confounder, smoking, but also smoking and obesity lead to cardiovascular disease, which in turn will cause mortality. But there were some unmeasured variables, for example, congenital heart disorder, that could be a common cause for cardiovascular disease and mortality. The point is that when you look at the DAG and there's a variable, and there are more than one arrows who are pointing at it, gliding in it, that's a collider. And when you have a collider, you cannot adjust for it, because when you adjust for it, you're going to completely reverse the results. So here in this example, we see that smoking and congenital heart disorder and obesity are all colliding with cardiovascular disease. Therefore, you should not adjust for it. And when you adjust for it, you're going to get biased results. And so this is very nicely summarized in this paper from 2015 that explains the obesity paradox, and it's very much applicable to other diseases that reported the obesity paradox. So to summarize, when we have confounders that are associated with both the exposure and outcome, we need to adjust for them. But when we have mediators or colliders, we do not adjust for them. And that's it for me.
Thanks, Galit. Nisha, we'll turn it over to you.
Yes, alrighty, let me screen share. Is everyone able to see my screen?
Yep.
Perfect, thank you. So I'm one of the last fellows to do Journal Club, and so the article that I picked was this one, which is evaluating the accuracy of 5 commercial sleep tracking devices and comparing them to the actigraphy as well as polysomnogram. And the reason I picked this article is because the amount of times in clinic that I have a patient tell me, hey doc, my Fitbit tells me that I am not getting deep sleep, or that their device is telling them that they're only getting XYZ number of hours. It's a lot. It's many, many times that they are telling me this. And oftentimes I'm telling them that these devices may not be accurate. And I wanted to know whether what I'm telling them is accurate or not based on research. And so when I came across this article, I thought would be a good one to use for Journal Club. So just a quick little introduction. A lot of us already know this, that sleep, we use physiological changes in brain activity, heart rate, blood pressure, body temp, respirations, eye movements, and even muscle tone to categorize sleep and categorize the various stages. And we do this with polysomnograms. It's our gold standard method of characterizing sleep. While taking some of these physiological changes, companies across the world have created consumer tracking devices. There's 2 types. One of them is the wearables. So these are devices that you can either wear on your wrist, like a watch, or on your finger as a ring, and they have sensors that would look at either movement, cardiac activity, temperature, or all 3 of those. The other type of device is a non-wearable. They're also called nearables. they're typically measuring physical change, cardiac activity from the bedside or even under a mattress, and they do not have any direct physical contact to the individuals. And so this article in particular looked at the performance of both these nearable devices as well as the wearable devices and compared them to actigraphy and PSG. And the various sleep parameters or the variables that they were comparing were total sleep time, wake up after sleep onset, light sleep, deep sleep, and REM sleep. So before I kind of start talking about the article, I just wanted to create a little slide here to show the devices. Very minimalistic. They're kind of small devices, easy to wear. And I think that's what really attracts a lot of our patients to these devices for them to use overnight. But these are the 5 that were used during the study. So Fitbit Inspire, which is the first picture on your left. The second picture is the Fitbit Versa. The third is the Garmin Vivo Smart. And then the Oura Ring, which is very popular among the adolescents right now. The last picture is the with things on, it's a mat that you put underneath your mattress. And then the fourth picture is the ActiveWatch. I also have the cost up there just so that we can get an idea of how much these devices cost for patients. Some, I was surprised, some are 80, but then there's others that are all the way up to 100. So that plays a role in what patients are able to afford, and then also what these each devices measure. So coming back to the article, I have this chart here because it's important for us to discuss the participants. There was 53 adults, 31 were female, and 22 were male. And it has the age, the BMI, and 2 other factors or 2 other important things where they had these patients fill out questionnaires. And this is to determine if they're someone that's a morning lark or a night owl. And that is the morning evening questionnaire. It looks at human circadian rhythm through a questionnaire format, and any score between 42 and 58 is intermediate. So anything that is more than 59, you're a morning person. If it's less than 42, then you're an evening person. And so I want that to be, if you look at the median here, it was 45. So these patients were intermediate. They didn't really have a circadian rhythm component. And then the last questionnaire that they used was the Pittsburgh Sleep Quality Index. This is to quantify whether a patient has poor sleep or not. They're asked questions, and if they had a score more than 5, it's categorized as poor sleep. So here our patients had a mean of 5.9. So reviewing the chart, what are your thoughts about the participants and like the characteristics?
So I think you kind of mentioned a few. One is that they're non-obese, like their BMI is like I think 23. So and then you also mentioned they're not like their chronotype, they're not night owls or like morning people, so they're kind of in the middle. And then you said the Pittsburgh sleep quality was around 6, so it kind of indicates that they just have poor sleep hygiene. Or yeah.
And then any thoughts about the sample size?
It was small and more females than males is what I'm seeing.
Mm-hmm. And what about the age?
Pretty young, like at like younger population.
Yeah, exactly. So yeah, same thoughts. The population seems to be more on the younger side, and they don't have any other sleep concerns. I mean, they are intermediate in terms of circadian rhythm. They don't have a advanced stage or a delayed sleep phase, and then They do have poor sleep, but it's hard to tell off of the Pittsburgh Sleep Quality Index what that means. It could mean various things based off the questions that I looked at, but so this is important for us to know on who the experiment was done on. And so with the methods, so these 53 young adolescents, they were asked to wear the devices or have one of them placed under the Withings mat to be placed under their mattress during their PSG. So these patients were already set up to be scheduled for PSG. And if they they were allowed to have these devices on at the same time as the PSG was done. And I think the article even had a kind of a setup where 2 devices would be on one wrist, another 2 would be on the other, and then you would have the Oura ring on a finger and then the mat underneath, in addition to being hooked up to the electrodes and the belt and everything. The exclusion criteria I kind of copied over for this slide, and they have an extensive list of it, but what do you guys think about the exclusion criteria?
Self-reported is very subjective, so it's whatever they want to give.
Exactly. So there's concerns whether things could have been missed, or if they have certain past medical histories or certain comorbid conditions that we weren't aware of. So yes, that can definitely play a big role on sleep. So that's a good point.
With
Any-
all the,
I'm sorry, what was that?
oh, sorry, with all the exclusion criteria, it's not, it seems like it's almost tailored to a very, very specific population, because people who don't have any of the following, it'd be really hard to find that, like, for example, excessive caffeine, like, that's a little subjective too, and so the alcohol, this is tailored to a really very specific population.
Yeah, exactly. And just like how you said it, Yama, they're trying to avoid anyone that is on medications that could possibly change sleep architecture. They want patients that are getting enough sleep, so there isn't maybe sleep deprivation or also any kind of substance like caffeine or alcohol that can also, once again, play with that sleep architecture. And looking into this, a lot of these companies that make these devices, when they experimented with these devices, they wanted patients with, they quote unquote say, normal sleep architecture. And I think this is exactly what they were trying to do with this study. The other thing that's interesting is they wanted to avoid anyone with abnormal sleep patterns, so no napping, but that also I think includes those that don't have possibly like OSA. They mentioned their restless leg insomnia, but I think none of the patients here also had OSA, so that plays a big role too. And it's important for us to keep this in mind. So we talked about the exclusion criteria. What do you guys think about the design of the study where patients had all these devices on? And do you think that this can, if we have findings, can we generalize this to the general public?
Well, because they exclude all the abnormal people that have, or not abnormal, people that have sleep issues. It's not reflective. So
Exactly.
it's hard to say how good it is, and when we have no abnormal.
Yeah, absolutely. I agree with that. What about the fact that they did this just one night when the patients came in for their PSGs? Like it was just that one night that we looked at.
Probably not enough time, because, it's just like a night-to-night variability one. And then two, like you're sleeping in a different environment too. I think it's better to kind of see how they do over time.
Yeah, exactly. So like you guys mentioned, there are limitations where we may not be able to apply all of the data to the general public, and that's something that we'll keep in mind of. The other question I had is, how might you guys think the simultaneous use of all of these devices at once can affect the data? So if the patients are wearing 5 devices or using 5 devices, I'll say, as well as having electrodes, the nasal oral pressure, the thoracic belt,
Mm.
I was concerned that there might be noise. Sorry.
And
I thought there
think-
might. Yeah, go ahead.
Sorry, I think just adding all those devices gives less real estate for the patient, like, there's less room to go and move around, so to speak, or it's just more things on them, so it just bother them. I can see that's bothering them. And I think another thing is that it would actually more so affect the patients too, because, if they see something on their device that conflicts with the PSG, I can see that as like causing a little bit of stress for the patient. And whether or not they thought they slept well, they didn't sleep well, and then the PSG says otherwise, so there might be like some sort of confusion or just, unreasonable stress the patient goes through.
Yeah, absolutely. Our patients already, right, when they come into clinic are already saying, hey, I'm not sleeping enough, but the PSG said this. But I definitely agree, Emma. It definitely plays a role with the concept of sleep for the patient during the day or during the night of the study, but then also it's not comfortable and there's multiple things that are being, or should I say things that are occurring for the patient that might be too much. In terms of the actual kind of devices interacting with each other, that's where I was concerned about electrical noise or impedance, if that also could possibly affect data. So kind of keeping all of these questions in mind, I was going to transition over to our
That
data.
looks like Kathy has a question or a comment before you transition to the next section.
Oh, yep, the chat. Sorry, I haven't been monitoring it.
No,
Um,
you're good. I've got you.
Can you hear me?
Yes,
hear me?
yes.
So I just want to say Neeraj also said dominant versus non-dominant hand could matter. Probably not so much because it's during the sleep period, but they're not doing any wakefulness, but it still could matter. And then proximal versus distal on the arm, because these are movement based and your arm's a lever. But there's like a big omission in this study, the way it was done. And we've written about like how these are supposed to be done. And what they didn't do is they didn't do something called an epic by epic analysis. And an epic by epic analysis is where you compare the actual simultaneous epic to the device's output at that exact time. And that matters, right? Because like these are all aggregated summary values, right? And like when you think about how we don't really know exactly how these machine learning sleep classifiers are made because it's intellectual property, but they're likely made on tons of healthy people's data who have a normal breakdown of sleep stages, right? And so the algorithms are trained on that and they're going to perform very well on that because they know what to expect. And there might even be variables like time of day that are in there, right? So if you're not looking at what's actually happening and just the aggregate over the course of the night, it would be expected that they would perform really, really well, right? So I thought that was a big omission on their part, and it's probably why it didn't end up in a very high impact journal. But they did overscore the PSG, which was good, and they have multiple devices. But sorry, I'll go ahead. I was just bothered by the epic by epic analysis omission.
Yeah, exactly. I believe that they weren't able to get the epic by epic because of the algorithm, and they all want to keep their algorithms a secret.
Yeah, they'll almost always give you epic by epic data if you work with the company because there's like hundreds of papers like this where they have that data.
Awesome. Thank you, Dr. Goldstein and Dr. Kaplish. So yeah, I did question which hand they were using, but they just used 212 is what they mentioned in the article. So kind of going into the data, I don't want to spend too much time kind of looking at the numbers, but I rather want to look at as a whole. But real quickly, as this was one of the parameters that they used, total sleep time, you can see that certain devices, I think it was the Vivio Smart, Withings, and Actigraph, they overestimated time compared to the PSG. And then in terms of agreement, which is when we're looking at the LOA, the limits of agreement, it looked like the Inspire, the Versa, the Oura Ring, and the Withings had appropriate agreements, whereas the other devices did not. And then for the wake after sleep onset, this one, it looks like all of them kind of overscored compared to the PSG, but the Vivio Smart very much underscored the amount of time that was wake after sleep onset, and all of the device had poor agreement because we want the agreement to be less than 1 here. And then for light sleep, for the devices, it looks like all of them, once again, I think actually no, Inspire and Versa and Vivio Smart overscored, but then the Oura Ring and the Withings underscored, but they all did not have appropriate agreement. And then for deep sleep, in terms of overscoring, it looks like the Vivio Smart overscored for a bit, or Oura Ring overscored, and then the others were slightly underscored. And then the last one is REM. For this one, it seems like all of the devices overscored, with Vivio Smart overscoring quite a bit, and then they all did, I think only Inspire and Versa had appropriate agreement, whereas the others they did not agree. And I think this is a better way to look at the data as a whole. So absolute bias, this is kind of like the mean difference. And we want to look at the absolute value that are less than 30 is what we're using as a key here. So the green means that there was a good correlation of the stage that they were using and then the device. So based off of this, it looks like all of the devices were kind of all over the place for the various stages. So for example, I'll use Inspire as my example here. It was great when it came to evaluating total sleep time, light sleep, and REM, but not so much for wake after sleep onset or deep sleep. And just going across it, it seems like none of these devices, maybe Withings here, who has a little bit more green boxes, it doesn't seem like these devices were good at depicting all of the different stages. They had some that were able to do a good job for like total sleep time, for example. Almost all of them but one, the Vivio Smart, was able to have good bias. So that's something to kind of keep in mind. And then here, this is the intra-class correlation, so the ICC. This is like a statistical measure of quantifying the similarity or consistency of the observations within a group. So this is to kind of see if the data is reliable for these devices or not. And once again, we want it to be on the higher end, so like 0.9 to 0.75. And it looks like that these devices were good at differentiating total sleep time versus not sleep time compared to the other stages. So they weren't really great at sleep staging. So to kind of go into the discussions, I kind of mentioned what metrics were accurate or captured that were consistent with the devices, but what are your thoughts on why there might be overestimates or underestimates of these sleep metrics?
And Nisha, there's one more comment from Kathy and then one from Jinhong as well.
Yeah.
So if anyone wants to unmute and read out your comment.
I could try to answer your question first, if you want, or do you want me to read the comment? I'm not sure.
Go for it, and I'll read the comments.
So I think, yeah, if we're using the heart rate and respiratory rate to estimate sleeps, to estimate sleep, sorry, rather than using like direct measurements like EEG, That could potentially be why we're overestimating. Like if someone's just lying still but is awake, I feel like that's gonna likely overestimate, sorry.
Yeah, exactly. It all goes back to, I guess, the algorithm and how sensitive the algorithm is. If, like Dr. Goldstein mentioned, how you're mentioning, like if someone is laying still, is that counting it as REM sleep, awake, or sleep, like part of total sleep? And we don't know because there is no EEG. So yeah, exactly. And then yes, Dr. Goldstein, sorry, yes, it is error bias. And then the other question is the limits of agreement reflective of precision and of the accuracy? So the ICC, the correlation, that is reflective of like accuracy and consistency, whereas the limit of agreement is precision, is so that you, if you were looking at the charts, if I go back, are the points within these two gray lines, so it is more so precision. So I think we've kind of been talking about the limitations of this study. How would you guys possibly address some of these limitations that we talked about?
Have a more diverse patient population or study population.
Definitely. And I know a lot of these devices, when they do come out with these new technology and new algorithms, they do, like Dr. Goldstein said, they test it on patients that are young and healthy because they want to show that these devices are working. But it would be interesting to see if we were to put these devices on someone that has OSA or severe OSA and see what happens. And if these data points are still accurate. And I know the article mentions that we can use these devices for our patients. I think I personally think that we have to still look at everything or look at the patient as a whole, just because you know, they're using their Fitbit at home and it says that they are sleeping. I mean, we are missing a big chunk of data. If we were to have EEG, we would be able to see if it truly is that it's recording all their sleep, or if they're awake and they're just sitting there still. So yes, definitely the population and the demographics is a big one. Now, my question to you guys is, I know the article mentions that these devices could be promising in the future. What do you guys think? Given the variability and the accuracy, how would you tell your patients to interpret the data?
I tell them it's a good start. They actually did something similar, Nisha, when during that sleep in Florida, they compared a lot of wearables and noted that the sleep staging was like at best like close to 50. That's a generous number. There's a lot of logistical problems you could say that vary even in healthy patients. It was kind of noted where the device is worn, which hand, how tight it is, like accounting for movement and light in the room, let's say. There's a lot of other things that are not measured that healthy people's could vary a little, like between patients. So it's hard to say exactly.
I agree, definitely agree. I think after reading this article, I think I'm still going to be saying the same thing, that I'm glad that patients are using these devices and they have something that they can use, but I don't want them to be very honed in on these numbers. Rather them look at it as a whole. You know, I am getting sleep. or I'm not getting sleep, but then maybe they can come and talk to us about it. But I do agree. I think there's a lot of variables at play here. I do think that maybe in the future, if algorithms change and there is a, let's say, a variation of how they're collecting these data, then there could be possibly a way that we can use these devices at home, or maybe be even like part of home sleep apnea tests instead of using the ActiWatch only. But I think we're a little far from that. Any other thoughts or comments?
So I would, when you're talking to your patients about this, one of the things I would also educate them on is that the way sleep is traditionally defined is by electroencephalogram. And these devices don't measure EEG. They don't claim to measure EEG, right? So how are they determining sleep? They're determining it by algorithms applied to motion and cardiac autonomic activity, right? Like we think primarily heart rate variability, but probably lots of different things. So you're measuring you're measuring changes in the physiology that are like distal, right? So even though it's not EEG, we're trying to model that data to approximate EEG, but it might be a completely distinct thing, right? Like maybe the cardiac autonomic activity and motion during sleep is very, very important. And we shouldn't be necessarily, I mean, even though, because we have no other gold standard, we're using it to approximate EEG based sleep, but it's a completely different construct, right? Like we would never look at someone's sleep diary and say it doesn't match PSG, right? Because we know we're measuring something different about the sleep. And there's a thought now that these are probably measuring a different aspect of sleep than what we see with EEG. And they actually work, like, as far as wearable sleep tracking, they work really, really well. It's, like overall equivalent to, or most studies show better than what's been cited for actigraphy. And when they compare to actigraphy directly, it's oftentimes a lot better. So you have to think of it not so much as a sub for PSG, but could it be a substitute for actigraphy in the future?
Well, in this study, there were some better results than actigraphy when they were all compared to polysomnography. So what does that say about the medical grade, quote unquote, actigraphy measures?
It matters which one you're talking about, right? Which device? Like the new devices record other things than the ActiWatch.
Look how much money we can save if we get medical grade.
Yeah, correct.
Well, when it goes to certain journal editors who are probably handling a lot of the studies on this topic, are those journal editors, of course, not referring to anyone here, going to be open to the studies that are done with the non-medical grade instruments?
So it depends on the methodology and the description, right? So it started with everyone saying, you can't use these instead of actigraphy. Actigraphy is validated. And so then now there's all these performance studies that demonstrate that these devices perform at least as well or probably better than actigraphs. But the difference with actigraphy is the process that, like, the methodology you use with it, right? So it's not completely passive. The patient still has to identify when they're getting in bed and getting out of bed. The data is cleaned. We know what software version that we're using. We know we can change the sensitivity based on different populations. And that's not something that you're typically going to get with an off-the-shelf wearable. But you can do things to make your off-the-shelf wearable use approximate kind of the rigor that actigraphy has. And we could give you code for that too, that we used on Helen Burgess's study, because Helen was not excited about using Fitbit because of the rigor issues and how skilled that her team is at cleaning actigraphy data.
All right. Well, before the end of the hour, I hope you're going to take a vote as to which device we should each be buying.
Well, definitely not the Vivo Smart. I feel like that one did not do well on most of the categories.
There's also a comment from Montita. I don't know if you saw about orthosomnia as well.
There is
Like
orthosomnia.
pursuit of perfect sleep.
Yes, that is very true. I think a lot of us get very honed in that looking at these numbers, and I have patients that literally will look at their watch and look at their Fitbit in the middle of the night just to see where they are and how their sleep is. So I think that's something we also have to be mindful of too.
I don't see any other hands up or comments in the chat. So great job on your journal club and picking a very timely paper, generating great discussion.
Thank you.
Can someone give their advice on which one to get? I thought Versa did well, and I mean, if you're looking for well in several measures, are you saying you should just get all 5 and wear 2 on one wrist and one and 3 on the other?
I think the
Fitbit has the
Fitbit.
most data. Yeah.
Which
Sorry, go
does?
ahead.
Fitbit has the most data on different models and the like largest volume of study.
So if a patient asks, I guess that's what we'll say. And
Inspire, Ulta, Versa, they're all pretty good.
all right, well, right there is an actionable conclusion from this journal club. So thank you for doing it.
And I probably out of time for, were you going to talk about proportional bias and heteroscedasticity at all, Nisha?
No, I stayed away from that.
Okay. It's interesting, but we probably 4 minutes is probably not enough time.
Yeah, it would probably turn into an hour lecture.
Okay. Great job. Thank you.
Thank you.
you.
Interesting.
Thanks, Nisha. Thanks, Galit.